The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Well, hello again, and welcome to the Pediatric Lounge. This is your co-host, Dr. Herb Bravo, and today, Dr. George Rogu, our co-host, will be joining us. This is the episode right after Hanukkah, Kwanzaa, and Christmas. And we have had a very long but successful year, and we wanted to take a minute to thank you all for listening to the podcast, making it a success, especially our friends at Peds United listserver. We're also very proud of our coaching team and group as we go on to 2023. We wanted to take this opportunity before I introduce Dr. Nick Rogu from RBK Pediatrics to thank you all once again and to wish you a very prosperous 2023 full of love, full of joy, good health, and cheers. We hope to see you at various meetings next year, including PMI in Houston, and we have a surprise that I am not allowed to say yet when, but hopefully we will see each other in person. Till then, have a very happy new year. Hi there, George. Good to see you this Tuesday morning.
Hey, Herb. It's Tuesday morning, once again, elevating great physicians. And today we have a specially great physician, Dr. Nick Rogu, aka little brother of RBK Pediatrics. He's going to talk to us today about implementing an ADHD evaluation and management program in a private practice and actually making some money on it.
Good morning.
Morning. Welcome
Thanks
to
for
the
having
show. It's a pleasure to have you.
Thank you.
So, Nick, we always ask everybody, including your brother, why did you become a pediatrician?
Well, the answer is pretty basic, and I'm sure you've heard it before, but I prefer working with children rather than the grown-ups.
I thought it was that your brother bullied you into it.
Well, not bully, but I'm sure he persuaded me to some degree. It was an offer. I could not refuse.
And I kind of like to change the subject of the podcast and just make it, what is it like to be George's little brother and work with him every day?
Well, we have two locations and we usually work in opposite locations.
That's not true. On Monday, I worked with you. On Saturday, I worked with you.
We have a buffer, but we work together as well.
So you lead the ADHD and the mental health program for the group?
I'm one of the doctors who participates in this program. I'm one of the
he leads it.
Yeah. And so tell me a little bit about, first, why did you want to create a ADHD program within the practice?
Well, during my residency program, I gravitated towards the developmental behavioral track, primary care. And there was a need for it. There's just not enough access in Long Island, across the United States. So there was a need, and we had the opportunity to fill that need, and patients appreciate it. I think we're doing better care for our patients because we've implemented this program.
And as you were going through the implementation steps, I'm sure you encountered some adversity. Do you remember what was the biggest pain points to get this off the ground?
Well, trying to standardize the approach, trying to get everyone on board, gauging the comfort level of some of our older practitioners. They may have not been comfortable, managing this. Usually they'll be quick to refer out to the neurologist, the developmental specialist, or the child psychiatrist. And the waits have just become longer and longer, 6 months to a year. So we had to take matters into our own hands and develop this program to help our patient population.
Yeah, actually, when we started it, I think it was back in the day of paper still, Nick, right?
Absolutely.
And the problem was a lot of it was still in the day when you were seeing 4 to 5 ear infections an hour.
Right.
And a lot of the doctors were, well, how can I see 3, 4 patients and he sees only 1? How does it generate more income than my 3? Fast forward 20 years, you don't see 4 ear infections in an hour. If I have a month, if I see an ear infection to show a student, it's a big deal.
Right.
So,
And so it's always the case you're trying to implement a new program. There are certain people that are skeptics. So how did you win them over?
Well, we just had to explain to them that this is a necessary part of pediatric medicine moving forward. And just because they didn't receive training during their, residency programs back in, 80s, maybe even early 90s, things have changed. This is part of our training now.
Yeah. And so when you, so let's run through the process. So at what age do you start screening the kids for inattention or hyperactivity, and what are you using to screen?
We're using the pediatric symptom checklist. So during our routine well care, we're screening for children younger than 5 years of age. And parents usually are pretty good at bringing to our attention their concerns. My child is more hyperactive, more impulsive, more inattentive or distractible than my neighbor's kids. And they just seem to be more of this or that. And in retrospect, a lot of the parents say their child is diagnosed when they're 5, 6, or 7, that I saw these signs as early as 3 years of age. So actually now we can actually do preschool assessments as well before 5 years of age. Between 3 and 5, we can sort of gauge the level of inattention, distractibility, impulsivity, hyperactivity in a preschool child.
Well, and so so I'm working in your office. The screen says that they're inattentive. What would I do with that child next?
Well, basically, we continue with our well care. We do what we need to get done in order for the child to participate in school and sports and activities. And then we go ahead and we set up for a future consultation, an ADHD evaluation. We give the parents the Vanderbilt questionnaires. We give a set for the parents to give to the teachers. We screen for any comorbidities or co-occurring conditions, anxiety or depression in a younger group to grade school, teen, adolescent. And then we had them come back with these completed forms. We assess the level of interruption in their daytime routine, and we take it from there. Then we set up a second visit, which is called a TOVA test, and that's short for Test of Variables of Attention. It's a continuous performance test, and it checks their ability to pay attention to a boring, repetitive, monotonous task. And it'll be the longest 20 minutes of their lives if they have ADHD.
And this is a computer-driven test?
It is. It's
And
done on a laptop, just a little simple clicker with the visual stimulus on the screen. And when they are in the upper portion of the screen, they click to respond as quick as they can. When it's in the lower portion of the screen, they're supposed to wait. And we see how many times they click impulsively or they fail to click when they're supposed to. So it gauges their level of distractibility, inattention, impulsivity.
it's a simpler version of Pong, if you remember Pong.
Yes, it does remind me of Pong.
And how young can you be to be tested with this?
5 years of age. It's a standardized program, so it's based upon a comparison population. So from 5 to 18 years of age.
And it's been validated. So there's standards and standard deviations, or I'm not familiar with it, so I'm very interested.
Yes, this TOVA testing program has been around for, I believe, 2 decades. Right, George? I believe so.
For a while, yeah.
Yeah, and it's gone through its, versions of, revision and improvement, but the model is still the same. It's called a CPT, a continuous performance test.
And there's a CPT code?
Yes.
Yes, it's neurobehavioral testing.
Okay. And so that's how you charge for it.
Right.
Do you find it really, it solidifies your clinical intuition? Is that?
I think it just adds another layer of reassurance that we're doing the right thing. It gives you more of an objective assessment, where when we do the Vanderbilts, depending on the teacher or the parent, whether it's mom or dad, whether it's the math teacher, English teacher, or the art teacher, it's more of a subjective assessment. So this more gives more of a black and white, an objective approach, and it just helps us kind of zoom in on our final diagnosis.
And for the comorbidities, are you using a standard, inventory like for anxiety and depression, or do you just ask the questions?
Well, when we do our pediatric symptom checklist, it touches on some of those areas, and it kind of prompts us to go a little further. So when we're screening for anxiety or depression, we actually use anxiety rating scales. We use depression rating scales as well.
Okay. And how about the other thing? I think some of these kids with AD have some learning disabilities.
They do.
Is
More than 20% of the children with ADHD can have learning disabilities, speech delay, other fine motor issues. So they could benefit from speech therapy services, OT, in school as well. And if they have something along the lines of a learning disability, for example, dyslexia or dyscalculia, that ADHD treatment doesn't help for that. That's more of a teaching method. A learning method has to be implemented. So we work closely with the school. Besides a 504 plan, they might need an IEP, to address those concerns. More neurobehavioral testing.
um,
Are there any other comorbid conditions that you guys look for? I know that with Dr. Riley, there's things with his metabolic stuff, aggravated
Well,
ADHD. I don't quite
yeah,
understand it, but
I'm sure Dr. Riley mentioned ADHD and obesity are intimately intertwined. So the impulse control or lack of, thereof to overeat is pretty significant. So when we have children with obesity, we're also noticing that they may have some impulse control kind of rooted in ADHD, and that can negatively impact them. So when we address their ADHD, for example, if they're on behavioral modifications or if they're on medications, it actually might help kind of rein in their impulses to overeat and stick to a regimen of healthy exercise, dietary management.
and so once you've diagnosed it, it's going to depend on the age what you choose for therapy. Um, but in your office, you or your team doesn't actually do any of the cognitive behavioral therapy. You refer that out.
Right. We refer that out to our local specialists who that's their area of expertise. We sort of go over what they do. We talk therapy. We mention that to the children. It's talk therapy, play therapy. To the parents, sometimes it's family or sometimes it's individual. Sometimes the parent is attending with the child. Sometimes the parent sits outside in a waiting room, and then the therapist might come after and tell them what they've done. It's not a one-time, thing. It's ongoing. It's weekly or every other week sessions for the entire school year.
Yeah. I recently read a book called The Optimistic Child, from Dr. Jane Gilman and the psychologist at UPenn. And they had a really interesting, very, very simple version of CBT.
Hmm.
And they say you need to start by training the parent, because if the
Right.
parent doesn't model the behavior, the kid can't learn the behavior.
Right. So parent training, very important. And we do try to take some time to actually counsel the parents on parenting a child with ADHD is different than parenting a child without ADHD. And typically when the child has ADHD, one or both of the parents have some degree of ADHD as well, knowing that it is familial to some degree, a greater degree than not. And so a parent with ADHD may not have the skill set to manage the child appropriately. So they need training, they need help. They definitely need the resources in the community.
Yeah. And so it's very interesting in this book that they said the very simple explanation of cognitive behavioral therapy that you can teach a parent is ABC. And I'm like, what, well, isn't that the airway, breathing, and circulation? It's no. It's first, what's the adversity? And I think this is very important for the parent of an ADD kid. The adversity is that he ran out of the house without the homework. And then B, what's the belief? So your standard belief is, here he goes again. He did it to just ruin my day so I can have to cancel the meeting, go take the homework. But the belief really is he doesn't know any better. He's just impulsive. And based on your belief, there's a consequence. So if I believe they did it intentionally to just make my day worse, it's going to end up in a fight. I thought it was a very eloquent explanation of how to slow down your thinking.
Right.
And once you teach the parent to think in those ways, they can start teaching their children to slow down their thinking.
Right.
Um, Very interesting.
Yeah.
Now, I see online advertisement for a lot of ADD coaches, and I'm not quite sure if that's legitimate, necessary, or just another way of getting people to pay for a service that's not paid by insurance.
Well, I think it's part of the psychotherapy, psychological counseling that's out there now. And basically, I think it's just another branch in that field. It's more of a, working on the executive functioning skills that children with ADHD along, the years of schooling affects them in a negative way. They can't get started in the morning. They have trouble getting started. They have trouble keeping that momentum through the day. They can try to keep it together for the first part of the day, but after lunch, they crash. They come home and then they crash again. It leads to a lot of struggles in the family, at the personal level, at the family level, at the social interaction level. So working on those executive skills, organization, time management, prioritization of responsibilities, following up on what they needed to do, taking home their materials, bringing it back, not forgetting their textbooks, their book bags, whatever it is. These executive functioning skills really are important. And that's why a lot of children who kind of coast on their natural abilities through elementary school, middle school, high school, and then they hit college, and all of a sudden they didn't know how to study. They didn't know how to take notes. They didn't know how to manage their time. And then they sort of fall flat. And then they come back to us and say, I think I struggled all along, but I was able to kind of cope and manage and get by. But now I'm seeing that I can't take it to the next level and I need help.
How do you know
Right.
that kid is not your college kid that's just looking for Adderall as a fix?
Right. So basically,
That's a
we
tough
have to go back. It's not possible. It's very unlikely to speak with their high school teachers anymore 2 years out. So it's also unlikely to speak with their college professors because they don't know them from
a whole other.
sitting next to them. So we rely on self-report. We rely on parent input, and we take a look at the big picture. If we see that they had straight A's throughout and they had never had any difficulty, and all of a sudden now they're complaining of, that they're having difficulty, we're not very quick to just dispense medication. We would recommend counseling first. They have workshops on campus that help at the student, services to work with an organization, and note taking and workshops like that really make a difference. It's just building their skills. But yeah, there are some kids who might abuse these substances, so we really, keep it on a short leash.
Yeah, I had a kid who was the son of a friend of mine who came back from college, said he was struggling. And I said, he knew all the things to say. And I said, all right, well, I can't treat you long term because you're not here.
Right.
But I can certainly give you a 30-day script till you get somebody at college to help you with this. And then he called me again. And he said, you think you could give me another script? I said, no, I told you I would help you in the interim. But if I'm not seeing on a regular basis, I can't be writing for these medications. Unfortunately, after he finished college, we found out he had a heroin addiction.
Right.
So I mean, yeah, that's the one bad case. For that one kid, there's 99 that are actually reaching out because they really do have an attention.
Right. And most of the times with the ADHD, it presents itself a lot earlier than in the college level. So
Yeah.
for every one college student that we get with this sort of concern, we probably get 10 grade school age children with parental concerns.
Mhm.
Yeah. So once you do the evaluation and you decide that they're of an age to be appropriate to use medications, you start the medications, and then do you see them back in 2 weeks after you start the meds, or?
We do. We start low and slow. We never, aim high and then back off. We start low and then build up gradually over the coming weeks. And we tell them this is not an overnight change. Basically, it's going to take some time to find the right dose. And we do explain sometimes the biggest kid could require a lower dose, and the smaller child can require a greater dose. It really depends on a few factors and their metabolism, the way they, process medications, and the pathways involved really dictate that. And then, of course, you have a starting weight and height, to kind of build off of. We have our ways of doing things, and the parents are very good about following up. So yes, anytime we start a medication, we see them in 2 weeks to assess their response or their lack of response. And we also check for side effects, appetite changes, moodiness, irritability, change in personality, change in sleep habits, headaches, abdominal complaints, palpitations, dry mouth, anything like that, or lightheadedness where they feel like they're going to pass out. And that means that perhaps the medication might be too great a dose for them.
And do you have a standardized form? I know the Vanderbilt has a post-treatment form for the parents and the teachers, but there's also a medication one, right? I just don't remember what it's called.
Right. So we have our own. It's basically a medications follow-up. It's more of a checklist for response to medications. Sometimes the child might say, I don't feel anything different. They're 8 or 10 years old. They might not notice any change, but the parent and the teacher do. Sometimes the last person to notice is the individual actually taking the medication or receiving the treatment.
Yeah. Yeah. And then once you've got them stabilized, things have improved. You see them every month through the telehealth visit, but it's not necessarily you, anyone in the practice will.
So basically, I'm just trying to get out of the glare here. Sorry. Yes. So after we establish the effective dose, then they're free to follow up with any of our doctors who are comfortable renewing their medications. And sometimes just adjusting whether they need to go up a dose or down. But when it comes time to major changes in their medical therapy, they usually come back to me.
And do you, so we in Virginia are different. We don't send the electronic prescriptions for the controlled substances yet.
Right.
But one of the things that everybody talks about is that it's important for the kid to come in every 3 months to the office so that we can get their blood pressure and their weight.
Right.
Honestly, I've never seen anybody who's really, in a hypertensive crisis because of
Right.
Adderall. But do you worry a little bit about that if the kid's stable and are only seeing them every 12 months for the well child? And
Well, that's where, hold on, Nick. That's
Yeah.
where I can give you some of my experience. All right. So we had this one family. The girl went to school with my younger son. And she had this like 90-day, 120, like a million refills. She never came to the office. And then I see her one day. I go to pick up my son from elementary school. And I see the girl coming down the hall. She looked emaciated. All right. She lost a ton of weight. Nobody put eyes or hands on this kid for months. And it was the ADD meds that did it. And the mother didn't even see the problem. We brought her in, we ruled out, diabetes or any other medical concern, changed the medications around a little bit, and then she flourished. And the kid was a zombie too. And the mother thought that everything was working fine.
Right. Over medication.
Yeah, so these meds are good, but they need to be controlled. That's what it's called, controlled substances.
so how do you do it? How do you do it in your office? Like you do a monthly visit by telemedicine, but do you
And
have
every 3 months, we see them physically in the office to see them in person, to speak to them, to kind of get a feel for how they're managing in a positive or negative way. We weigh them, we check their vital signs just to make sure that they're growing, especially for the kids who are prepubertal. If they're not getting enough calories in because their appetite is suppressed, if they're not getting good sleep, then they may not be growing as well. All of a sudden, they're starting to trend downwards or flat line on the growth charts. That's an area of concern. So we consider alternatives to that, perhaps getting some extra calories in the morning or in the afternoon or the evening, perhaps taking breaks from the stimulant medications if it significantly, decreases their appetite, take breaks on weekends, holidays, vacations from school, summer.
So you gotta interact with the patients, with the families, with the parent, with the kids, see how they're doing. People need to be engaged, not just popping pills. Otherwise, we're just pill pushers.
That's right.
That's
right. And the executive functioning, the organizing the kid's life so they can be successful is almost as important as the medication, probably a much harder task.
Right. And that comes with a lot of practice and repetition and setting examples. And hopefully with time, as they get older, they mature a little more. They know what they want to do with their lives. They know what they need to do in order to achieve that, goal. And they may have to, sacrifice some things in order to do that. They might have to take longer to study. They may have to not hang out with their friends every weekend. They may have to sit in and study a little more to get that higher grade. But that comes with time. That comes with maturity. And children in grade school and middle school, even high school, may not have that maturity level just yet. Usually the teenagers, the high school going to college, they might say, I would like to try less medicine or without medicine for a semester and see how I do. There's flexibility with the schedule in college. You can go Monday through Friday, or you can go Tuesday and Thursday. So you can have days for school, you can have days for study. You can pace yourself, you can have breaks in between. So you don't have back-to-back classes all day. You have an hour between classes so you can sort of get to your next level of the whatever, building you have to get to, and you don't have to worry about getting there late. You have time to study.
Yeah. Yeah. So I'm going to tell you back your process and see if this is what the program looks like, right? So there is, you're the team leader or the advocate for the ADD program.
Yes.
In your office. You screen every kid with a generalized inventory and their well child exams. If you or one of your partners finds a problem with one of the kids, then they set them up with a consult for you, which is 45 minutes to an hour.
Yes.
And before they go see you, they've already been given the Vanderbilts. So they're not wasting their time. I often, when I'm covering a practice, somebody will walk in for an ADD consult, and all I can do is hand them the forms and say, well, go fill them out and then come back. And that makes people very unhappy.
Right. I think giving it at the time of their well visit on their way out just saves some time. So when they come in the next time, we have a head start. But there are some visits, they come to us cold with no hint of sort of a pre-workup. And we'll just start fresh at that time. We'll take the information, we'll take the history, we'll assess if there's any medical issues that need to be evaluated too. We do screening labs for everybody, fasting labs, checking their metabolism, just checking to make sure there's no vitamin deficiencies, iron deficiencies that can kind of present themselves, any issues that we need to address aside from the ADHD, but could sort of mask itself as some sort of learning issue or behavioral issue. I think it's very important to rule that out.
Okay. And then
the staring episodes could be confused with inattention, distractibility, lack of focus.
I guess that's why the neurologists, when they do the evals, they do EEGs on everybody.
Do an EEG, right? Just to make sure, especially if the parents say that they're kind of staring off and they have to say, hey, Eartha Sally, come back, and then they'll snap back into focus.
Absolutely.
With any suspicion, we would do that as well.
And so then at that same time, you're screening for comorbidities. Let's say just straightforward, inattentive kid, and you start medications. Then you would see him back in 2 weeks to see how they're doing on the medication and maybe need to increase it. So you see him back in another 2 weeks. He's stable or she's stable on the medications. Then they do 2 telemedicine visits with their primary care doctor, whoever they see the most in the office. And then the 3rd visit, they come in to be weighed in the blood pressure. So they're coming in 4 times in person, and a year, and the rest are all virtual.
Yeah, we try to be as flexible with them as possible. We know that when they're traveling outside of the state and they're in college, for example, that they may not always line up with those breaks coming back. So we try to be as accommodating as we can, but we also try to stick to our guidelines that we've established in the office. And if we set those parameters early, the parents know what to expect. And if there's an offshoot chance where it gets mixed up and they can't come this month, but they can come next month, we'll do that too. I mean, this is just the world we live in. We know that nothing ever lines up perfectly all the time. And if we're so rigid, that's not good either.
And then the TOVA, you do it at the beginning. Do you repeat it?
If necessary, yes, we can repeat it, and we can see how they're acting when they're on their medication and they're on their behavioral plan, and see if their TOVA result now puts them in a comparison set that is not classified as ADHD.
Okay.
We can do follow-up TOVA tests. We do follow-up Vanderbilt scales for parents and for teachers.
Okay. And then what do you measure to make sure that the program is quality? Do you measure anything on your population?
As far as response
You,
to medication, response to
not
behavioral
at the not
therapy.
on the individual level. How do you know that your program's a success? At the population level.
We're able to run analysis. We're able to run measures in the back end. We have
Okay.
analytics. We have a dashboard, and it can really help us gauge our patient population's response to our therapies.
Okay. And do you have any special survey of these patients to see their satisfaction with the care?
Yes, we have patient satisfaction surveys. Every time they come in for a visit, they will get a patient satisfaction survey sent out to them, urging them to be honest about, their experience.
Great. Great. And so that's how you know that you're making a difference at the population level. When you're in the exam room, when the kids' grades are up and the family's happier, you don't need a survey for that.
Right.
But at the population level, it's hard to see the forest when you're in front of the tree.
Yeah.
So
Mhm.
that's great. And I know that you and George work very hard with your EMR to try to get these population um, um, views with
Right.
the dashboard.
That's the whole
Uh,
thing with the program. You need to modify the EHR template to help the physician get through more complicated visits, because if he's going to type away everything that the patient says, which is usually a repetitive thing, it doesn't create that dialogue, that relationship with the patient. So within the EHR, we have these pre-made templates that do various things, and the physician picks whatever they think they're going to be doing, and the words are pre-populated. He knows the words. He wrote the words.
Great.
And this way the staff can just engage the patient and the family like humans, not like computer
Yeah.
monkeys.
Right. We really try not to just sit at the computer and talk to the computer and the parents are behind us. We really try to do FaceTime with the parents, and we try to type as little as possible. Everything is there, and we need to put in pertinent positives, pertinent negatives, and know when to leave out any unnecessary information. But we never cut any corners. We're very
Yeah.
thorough.
Yeah. That's one thing I really admire about what you guys have done out there at RBK. Um, you are taking care of the chronic problems, chronic diseases in an organized way, finding a leader, a champion for that one entity, whether it's ADD or asthma or obesity. And that person sort of is a teacher to all the other doctors and builds a framework where everybody can be successful. And at the end of the day, the kids benefit from that investment that the leadership does.
Right. Well, what happens is with the young new doctors, they're all of the new crop is a little bit more, I think they want to learn. Okay. But we had generations of doctors. I didn't learn about ADD, so I'm not going to do it. I didn't learn about obesity, so I'm not going to do it. I didn't learn how to put sutures in, so I'm not going to do it. I didn't know how to do ear piercing, so I'm not going to do it. I mean, you learned about inpatient medicine, and then they give up the job to the hospitalist. And people wonder why they have no jobs. You got to engage, you have to adapt.
Yeah, but that's true of anything. When I started, people love cefaclor
Yeah.
for ear infections, right? Well, when was the last time that anybody wrote for cefaclor? Nobody.
Changes, yeah. So you adapted.
I mean, I hate that I can't find Bactrim or Receptor, whatever you want to call it now. It's just not available anymore. You can't treat UTIs with it. But you got to change. I mean, science changes, and
Yeah,
we're in the business of science, and change. The most difficult part, I think, for me in these things like ADD and depression and anxiety is there's so much unknown from the physiology point of view of how the brain really works and how these medications work in the brain, that a lot of it is just learned experience. It's touchy-feely. It's not like, well, you got renal disease. What's your creatinine? Where's your BUN? What's your potassium? There's no measures like that when you're dealing with somebody with anxiety. It's all how it feels. And everybody's very different.
Yeah. But I think touching on the doctors, I think when they come into an organization, they start to see these things. they get interested. And then one day they come up and say, hey, I want to do this. I want to get involved. Teach me. And they usually, we can teach them.
Yeah. There's a lot of training, like sort of mini fellowships that are available now in the state of New York. And it really takes the primary care pediatrician, primary care family practitioner, and actually teaches them how to evaluate for ADHD, anxiety, depression, other mental health related disorders, and when to sort of manage it independently versus refer out to somebody with a more specialized, level of training. So really, it's child and adolescent psychopharmacology for the primary care pediatrician.
What I found is I did one of those mental health mini fellowships. What they were run by academics. So, I mean, I don't know about you, Herb, but how much schizophrenia did you manage?
I'm not going to manage. I'm not going to manage autism or
amount of
schizophrenia.
detail that they went into with schizophrenia and bipolar disease, all the rarities that should be managed by somebody else, they put it to the primary pediatrician, which basically I lost my interest in learning about that. I needed anxiety, depression, ADHD, and that's it. So that's what should have been the focus, but they focused on all the weird, it's like with medications that I can't even spell.
Yeah, I think they actually took that feedback and actually now created separate tracks. So there's a track for bipolar, there's a track for schizophrenia, and then the other one is more ADHD and straightforward anxiety, depression, identifying, management. And obviously they have a backup plan, and they can get you fast tracked to the front of the line with a consultation with a child and adolescent psychiatrist if necessary. So it's just another resource that we have available. And I hear that some of the residents during their training programs have the opportunity to do this during their residency program. So they come out with this training already.
That's great. And that's Project Teach, right, in New York?
Yeah, Project Teach.
Yeah, that's a very nice system out there. I think ours in Virginia is called Project Reach, if I'm not mistaken.
I mean, I did it back when it was called the Reach program back in 2004, 2005.
Yeah.
And it was great. And so it's had many levels of, sort of improvement upon all of the areas since then. And I think it's a great resource. More people should take advantage of it.
Yes. And the problem is in medical education in general is that we try to teach adults like we teach children, put them in a classroom and lecture to them. And as adults, we learn much better from peer to peer and smaller groups where we can share our experiences and what works and what doesn't work. And there's not a lot of venues like that for us to learn. Yeah. That idea of mentorship is very important. I could start an ADHD program if I knew I could call Nick at any time and say, I'm stuck. I don't know if this is anxiety or this is attention deficit disorder. This is what I got in front of me. What do you think? And, he says, well, no, you're doing good. Just try this and, let's talk next week and see where you're at. That's how we actually do learn. And as adults, I can go to 10 lectures and I still don't know what to do. I was going to ask you a couple of questions. Are there any books that you think parents would benefit from when they're dealing with a child with ADD?
Well, basically, I don't even think they need to go to books at this time. They can just go to the AAP, and they actually have a lot of resources there. Parents sometimes like to look online. There's an online community called CHADD, CHADD.org. It's a wonderful resource for parents, teachers, educators, professionals like ourselves to sort of connect. There's a parent-to-parent network. There's printouts, handouts. There's apps that they can download, little podcasts, just like this, that they can actually look at other professionals at different levels speaking about ADHD and how it affects them day to day and how to help. So it's almost like just a free resource there, and anyone can access it. And we get a lot of information from that. A lot of our handouts in our systems are from that, and they take it from the AAP.
So CHADD, CHADD or
CHADD.org, CHADD.org.
Okay, we'll put that in the show notes so people can find it. and on the website. Is there anything I didn't ask you that you think it's important for our audience to know about, the success of starting a program like this within a pediatric practice?
Well, you never asked, how do you make money on it?
Oh, I know you, and I know what your dad said. If you do good medicine, the money will follow. So I'm not worried
Right.
that you guys are not making money.
You got to pay for the doctor's salary, right?
Right.
It has to pay for itself.
No margin, no issue.
It has to be, because I'm doing these consults and Dr. Riley's doing his consults, that means we may not be available to see the well and sick patients that day. So another physician has to be working in our place. So it has to support a full-time physician.
And so how do you you guys have a very good team mentality, so you all work together.
Right.
But this helps you in negotiation with the managed care contracts. Is that
Well,
how
I
you
use,
make up some
I
of
use
it?
it all the time when I do the contract negotiations with Susan Madden and the Blue Crosses or whatever you're talking to. One of the key things I tell them is we have the chronic care program. We do, ADHD evaluation and management, obesity. We do the asthma care. We
Right.
don't do so much, but I do international adoption medicine. They used to be more popular, but it's just another thing. And then they see this stuff on the website and they say, okay, there's value to the guy down the street that just does ear infections.
Right. It refers a lot and
Yeah.
to the expensive
Yeah.
healthcare machine.
Right.
Yeah. What are any other thoughts that you want to share, Nick? It's been wonderful having this conversation with you.
Right. Don't be afraid to ask questions. A lot of people coming in to a private practice may just kind of do one thing and do what they know how to do. But if they're not exposed to it, there's always an opportunity. You're going to see enough with time. And if you just want to, take the lead and ask someone who has experience, how do I do this? What do I do? How do I start? What sort of materials and resources can I implement into my practice? And usually I have to say, your fellow, colleagues in the practice are probably supportive because they'll be happy that someone wants to take this on. And if they already do it, they might be happy that someone else is coming in wanting to continue to do this when someone else is sort of, going towards retirement age to continue what they've initiated.
Yep.
Yeah. A little difficult if you're a solo practitioner, right? And
Yeah.
it would be hard to be this good at ADD, this good at obesity, this good at asthma. And who sees the sick patients while you're got your whole mornings tied up in the consults?
Yeah, that's the problem. But I'm thinking from a solo practitioner point of view. If there were enough patients with ADD within your practice, you could designate slots of time, like 4-hour slots on a Monday or on a Wednesday afternoon. And
Right.
this is where I put them. And I deal with this on Wednesday, and that's it. Same thing with obesity. And I mean, the medicine, everybody can learn the medicine. Is there enough patient care, patient volume in your solo practice? I think there is.
Oh, I definitely think there is. Those three are major issues.
Yeah.
It's what we talked earlier this morning in the coaching class is, you got to lead with revenue, because if you're not paying the bills, it doesn't help anybody. Then you got to develop people, which is what you guys do, right? You go, okay, Nick, you like this, go take the courses, go learn about it, come up with a plan and, be the champion within the practice for this one chronic disease. And then you got to set the processes in place so that everybody in the team can be successful.
Correct.
So you standardize the process and everybody can fall into that train track and be successful and be comfortable. And the patient benefits a tremendous amount just because you eliminate a bunch of variability, so everybody knows how we do ADD. Everybody knows what to expect. The front person knows, the nurse knows, the doctor knows, the parent knows, everybody knows. And so that's how you achieve great medicine at the population level.
Yep.
You have any thoughts, Nick?
My, my concerns are, I wish I could help more of our patients, and there still is a wait. However, our wait is significantly shorter than anyone around. So if it takes a month to get their consults in, to our practice, and the parents are saying, hey, I don't have a month, to wait, I'll tell them, we're doing a good job at what we're, at how we do this, and it's worth the wait. Let's get all our eggs, in a basket and get everything done ahead of time. So when you come in, we're not wasting time, right? We ask the parents to be, as organized and prepared for their visits so that we can, make the most of that limited time. And if we can speed things up in any way, we always get them in sooner. There's always a cancellation. Someone's always sick. We'll call them up and say, someone canceled for tomorrow. Can you come down? And they're more than happy to do so. I wish I had more time to do this. And now we just have, 3 new physicians who joined our practice this fall. So I believe we're going to have some more consult days available for myself and Dr. Riley to do this and to help more of our patients who have been sort of waiting over the summer.
Oh, that's excellent. That's excellent. That's
and it's early enough in the school year to make an impact now, not lose the year.
Yeah, that's excellent. Excellent. You guys are doing great work. Well, I'm out of questions. George, do you have any questions for your brother?
I think you got them all. I think it's good.
All right, then I should let him get back to work, I guess.
Yeah, let him go to work.
Just getting ready to go.
All right.
It's been a pleasure hosting you. It's nice to finally meet you in person.
Right.
And hopefully we'll get to see each other in real, not via avatar and Zoom, in the not so distant future.
You'll see him at the OP conference.
Okay.
All right. So we'll see you at the OP conference in DC in April.
Yeah.
All right.
Well, thanks.
All right.
Take care.
Take care.
Thank you.
Thanks for your time. Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.